Hi everyone, I'm just going to give it a few minutes for a few more people to join and then we'll get started. And we are a couple of minutes ahead of schedule, so it might be a few minutes. Thank you for joining. We'll be starting in a few minutes. Right, has hit 2 o'clock, so I think I will now get started. So welcome to this afternoon's virtual information seminar on palliative care. I'm Neeru Nayak, Deputy Director of Care Campaigns and Support at Muscular Dystrophy UK. We've got quite a packed agenda this afternoon with a fantastic array of speakers. And today we're going to be discussing palliative care, and we'll also focus on answering your questions, as well as covering as many as we can that have been submitted in advance. We'll be using the Q&A function, which you should be able to see at the bottom of your screen. So please type in your questions and comments, and we will get through them during the discussion. To help us manage the technical side of the event, we will be calling on questionnaires to not ask their questions directly. Any questions we don't manage to cover and don't know the answer to, we will answer them through the website afterwards. So before we begin, just a note to say that our helpline is available for anyone affected by muscle wasting conditions, and do please contact us if you have any questions or you're in need of support. We can help you with information and can either support you directly or point you to where you can get support. So the number and email should be on your screen now. So you can call us on 0800 652 6352 between Monday to Thursday, 10 a.m. to 2 p.m. And then outside these hours, we use a voicemail service that is answered regularly and pretty instantly if it is something urgent. You can also email us at info@musculardystrophyuk.org. So if you do have any questions after this seminar or you need support in another area, do not hesitate to contact the team. And finally, a reminder, we'll be recording this session and it will be available over the next few days on our website. I'm chairing today's session, and to start us off this afternoon, I am absolutely delighted to welcome our panelists today, who will help us discuss and answer your questions. And today we are being joined by Professor Derek Willis, Dr. Shona Ladlaw, Dr. Emma Husbands, and Claire Bassey. So what I will do in a moment is I'll introduce you to each speaker and invite each of them to make a few comments about their role and their experience of palliative care. And as mentioned, we'll be using the Q&A function, which you should be able to see at the bottom of your screen. So please type in your comment and we'll feed them into this discussion. Any comments, any questions we don't manage to cover and don't answer, we'll seek to answer directly after the seminar. So, firstly, I'm delighted to introduce Professor Derek Willis, a medical director of the Severn Hospice and clinical responsibility for the inpatient unit at the Apley site. Professor Willis has an interest in palliative care for adults with neuromuscular conditions and has worked in partnership with the Robert Jones and Agnes Hunt Hospital to define what this service should look like locally and nationally. He's the head of the education department at the hospice and has an interest in medical ethics and philosophy. I'm also delighted to welcome Dr. Shona Laidlaw. Shona Laidlaw is a specialist doctor at the Prince and Princess of Wales Hospice in Glasgow and has been part of the award-winning young adult service for 4 years. Her background is in general practice and she was a GP partner before pursuing a career in palliative medicine. She has a special interest in neuromuscular conditions and transition from child to adult hospice services. Shona is a mum of 2 teenage girls, one of them who has spinal muscular atrophy. I'm also delighted to introduce Dr. Emma Husbands. Dr. Husbands is a consultant in palliative medicine across the community in Gloucestershire. After training at the University of Dundee, she worked in Hereford and completed specialty training in the West Midlands. Emma is passionate about neuropalliative care and has worked with the MNDA, Muscular Dystrophy Association, and Together for Short Lives, and is a member of the clinical committee of the International Neuropalliative Care Society. She enjoys a good jigsaw, a bit of Formula One, and always a cup of tea. Claire Bassey, I'd like to finally introduce. So Claire Bassey joined the Regional Neuromuscular Service at Oswald Street in 2016 as a specialist nurse. She's passionate about palliative care and the importance of a holistic approach. She qualified as a sick children's nurse and adult nurse in 1990 and has worked widely in palliative care for children and young adults in both acute, hospice, and community settings. She's completed a postgraduate specialist practice degree in palliative care for children and young people. Since joining the team at Oswald Street, she's continued to work with children and families with palliative care needs and developed experience in adult palliative care practice, including the development of the traffic light tool for identifying patients with palliative care needs, emergency and advanced care plans, and symptom control clinics. She's also a member of the RJAH Hospital Palliative and End of Life Steering Group, and also Shropshire, Telford, and I'm not going to pronounce this properly, Wrecking Children's and Young People's Palliative and End of Life Steering Group. So I am so pleased to have you all here with such an array of experience so we can just get some more information out about palliative care. So Professor Willis, if I could come to you first, if you could provide us an overview of what palliative care is, and one of the areas we did want to cover today is the stigma and misconceptions that surround palliative care. So it would be good to discuss that as well. So can I hand over to you, Derek?
Of course you can. Hello, everyone, and thank you so much for inviting me. Now, before the Shropshire police come and get us, we have to record that it's called the Wrekin.
I am sorry.
And the Wrekin is a big hill in the middle of Shropshire, which is believed to be a giant who lost his way and got turned to stone. So round and round the Wrekin is, we are famous for one thing in Shropshire, probably one thing only, and that's the Wrekin. So palliative medicine. Palliative medicine for this audience is probably split into two things. So there's the palliative medicine and hospices that you would expect that you would get from a children's hospice, where generally the emphasis is put on respite care and giving families a break, a place for children and young people to go to get some extra support. And part of the problem with some of the conditions that we've had with neuromuscular disorders, where kind of amazingly people are now living longer thanks to amazing therapeutic interventions, some of these neuromuscular disorders are becoming adult disorders. And part of the challenge for people like all of us on the screen is to work out when we're involved in adult palliative care, what those conditions, which we've generally never seen, what they would look like being treated by adult hospices. So palliative medicine can be associated with being a respite service where people can go regularly and have a break. And you generally find in the adult world that that model is not mirrored within adult palliative medicine. I guess the other thing that we see is palliative medicine, when it was first set up by Dame Cicely Saunders, was that she wanted to see how dying could be improved. So palliative medicine to begin with was very much about dying, and it was probably very cancer related. So most of the people that actually came were going to be had a diagnosis of cancer. And Dame Cicely's idea was that she wanted to show how end of life could be done well, and then the hospices would shut down because actually the NHS would take over and see it was a great thing. Well, we've seen how end of life care can be done well, but hospices haven't shut down and the NHS hasn't completely taken it over. But the stigma has remained that what a hospice and what palliative medicine is about is just about dying, and generally is just about for people who've got cancer. In the 40 or 50 years that the specialties kind of blatantly or openly existed, it's moved to going away from it just being about the last days of life to actually looking at some of the last months and years of life where we can help people who've got the phrase life limiting illness, where actually we can improve their quality of life. So the majority of my work really isn't with people who are in the last couple of days of life. It's generally within the last years and looking at symptom control, improving home circumstances, increasing quality of life so that people can live before they die. So when people get referred to us, they're worried because they think it means they've got the last couple of days. And no matter how hard we try, I think that's a stigma we're a little bit stuck with. So something like this helps get rid of it. So never ask me for a short answer because you'll never get it. But I kind of think that's probably in my head what this audience would think palliative medicine is. And the way that we've been doing it in the oswestry model is that I supplement, I add to what the existing neuromuscular center does. I don't take the patients over. I'm brought in as an expert, if you like, to talk about symptom control issues. And a lot of the things you generally expect with a hospice, like doing advanced care planning, about place of death, generally that's done by the home team themselves. I am literally doing the stuff about helping with pain, helping with appetite. Does that answer your question?
It does indeed, Derek, and thank you for being so detailed because I think it's actually quite helpful to be so detailed about it. So, just to add to that, one of the reasons why, as a charity, we're focusing on palliative care is exactly the just to be aware of the stigmas surrounding it. So, do you think there's any education resources that might be helpful to address some of the misconceptions around palliative care, possibly?
Is that still with me?
Yes, it is indeed.
God, I was hoping
But
that was going to
anyone else
someone else.
can
I had
join
the
as
really
well.
easy question. So there's a very dashing bloke on your website who talks about the North Star thing for Duchenne muscular dystrophy. Can't think where he was, but he he produces some very interesting things. So because it's such a developing field, the answer is that there's not an awful lot. But part of what we're trying to do today is having the conversation. And
Yeah.
sometimes I think local hospices aren't actively discriminating or not wanting to get involved with people with neuromuscular disorders. It's just that they've never actually thought that they have a role with it. So part
Mm,
of what we're trying to do kind of within Shropshire is my hospice doesn't have all the people that the oswestry look after. So I'm supporting hospices as they start to reach out and help people with neuromuscular disorders. So I think there's something about patients and carers knocking on the door of their local palliative care team. I've heard that actually you might be able to help, can you? But then my job is to and our job is to educate palliative medicine as a whole to say, maybe this is something where we've missed a trick. So maybe there's a bunch of people who we should always have been involved with. And I'm particularly thinking of people with myotonic dystrophy, where we're
mm,
quite used to dealing with people with motor neuron disease. But a lot of people who got myotonic dystrophy have really similar types of disease, types of progression, symptom control problems. And actually, we probably should have been involved with those people for a long time. I guess the only difference is, as people will know, the fact that as the condition goes down the generations, it tends to occur more earlier. So there's whole kind of more genetic counselling side of things that we wouldn't be used to. So there's people that should have been referred all along. There's people who are living longer, so are ending up with conditions that are our bag anyway. So I've had some people with FSHD. Am I all right using three-letter abbreviations?
Absolutely fine.
Facioscapulohumeral dystrophy, who have lived long enough to develop cancer. So the reason they've been referred to me as a palliative care doctor is nothing to do with their neuromuscular condition. It's they've lived long enough to have one of the other conditions we would look after.
Yeah.
And then, as I hinted at, folk with Duchenne muscular dystrophy who are now living into their 20s, and particular national hospices will no longer take people who are 18. So the challenge has been what we can actually provide, both as a centre, a neuromuscular centre, but also as my local hospice, to help with young adults, where it's going to be a very different model to children's hospices, but actually probably a different model to what adult hospices provide.
Okay, thanks, Derek. It is actually really helpful to hear about the conditions that would have relevance to palliative care as well. And I think myotonic dystrophy is one condition that we've had an influx of as well more recently in terms of the severity of some of the conditions and as it goes down the generations. Anyone else like to add anything? Shona, you've got your hand up. Thank you. You're on mute, Shona.
Thank you.
It happens all the time.
Just to follow on from Derek, I suppose that he's talking about local resources, just thinking nationally, sort of one of the charities with a nice big yellow daffodil, Marie Curie, have fantastic resources that are available. And actually, I think there's a couple of doctors who have written books who might be useful. So that's Catherine Mannix, with The End in Mind. And she actually shares two stories, one of a young man with Duchenne and another of a little baby with spinal muscular atrophy. And also Rachel Clark as well, who's a British journalist and doctor and hospice doctor. And what they've done is they're really trying to demystify what hospice work is, and talking about death and dying, but in a far more sort of approachable manner. So highly recommend those as additional resources.
Okay, thanks, Shona. I might ask you to share these with me afterwards, and then if you are listening to this as a recording or you're on the seminar at the moment, do get in touch with the info@muscular dystrophy and we can send you those details out. Emma, Dr. Husbands.
And I would just echo everything that Derek and Shona have already said. And one of the big challenges is that actually nationwide, there's a huge variation. So where I'm working in Gloucestershire, I'm probably doing a slightly different job to Derek and so on. And that adds to the confusion, really, because really neuropalliative medicine, neuropalliative care is evolving. And it's evolving because the management of these conditions have evolved in spectacularly positive ways. But I think that also means that we as a specialty are needing to evolve as well. And so that's something I envisage happening more over the years. And we are working differently with cancers now. And there's every expectation that we should be working differently with neuromuscular conditions as well. And simplistically, I see myself in my role as being a little bit more of the local support rather than a tertiary centre, because in Gloucestershire, our patients are generally going to other tertiary centres. And I will often be giving people a bit of an MOT and a service every now and then. And then when there's a breakdown, they'll come to me as a local garage. So, it's that element of sometimes dipping in and out a little bit more, but also being that local link to be able to be a source of knowledge, I suppose, for local teams who may not see these conditions quite so frequently. And one of the beauties of seeing more patients with neuromuscular conditions is you start to build those pictures of similarities. You build those pictures of, actually, we do see that. And now that people are living longer, we are seeing that complaint and these other issues. So you start to become able to spot the problems and recognise and hopefully then improve things.
Yeah, okay. That's really interesting and really helpful. Claire.
I know, just remember to unmute myself there. It was just to add in terms of resources, I think in terms of children and young people's palliative care, certainly, and I'm not sure it was Emma or Shona who'd mentioned it, but Together for Short Lives is an excellent website, and there's lots of resources on there for parents and families and young people. So I would recommend that website as well. I'm happy to share that in the chat as well.
Yeah.
Thank you.
Perfect. Thank you. Thank you, Claire. That's really helpful. Just a reminder for participants, as we go, just feel free to ask questions in the Q&A if you do have any as we go along. Derek, back to you.
Yeah, I guess one of the reasons that we're trying to produce some national guidelines, even though sometimes they're not really, there's not loads of details, is to try and make sure what Emma's identifying of, actually, you're lucky if you live here, you don't end up with anything over here, to try and produce at least a level of expectation of this is what should be provided at your local neuromuscular centre. So particularly North Star, which was the thing for people with Duchenne, it was originally children, and the adult one has just come out. We really emphasised that a neuromuscular centre should have access to an adult palliative care physician for advice. Yeah. We've been working on something for folk with myotonic dystrophy. Kind of fingers crossed that's going to be published again. So there's this thing about locally, but hopefully if we are producing national standards, again, that's something that people can point to. If locally you're not getting it, to say, well, actually, it says here that I should be able to have it. So going to various, spending long time trying to produce them sometimes feels like we're getting nowhere, but it feels really important that we are naming this and saying, look, if you're classing yourself as this centre, you should have access to that.
Yeah, no, that is really, really helpful. And I think as a charity, we could potentially support with trying to push that forward as well. So we can look at that some afterwards. So just moving on, if I could come to you, Emma, would you be able to, I know we've sort of talked about this already a little bit, but would you be able to explain the difference between palliative care and end-of-life care, as we do understand, and we come across this sometimes on our helpline, that the two are quite often confused? And then if anyone else would like to add into that.
Yeah, so nationally, the definition of end-of-life care is somebody who's expected to be in the last year of their life. And there is never a crystal ball to that. We can never absolutely predict when somebody is in the last year of their life, but that's the national definition. And within that, obviously, it includes the dying phase where somebody reaches the very end of their life. And palliative care incorporates that last year of life, but potentially extends, as Derek has described, beyond that and into the years leading up to that, as somebody is living with a life, potentially life-limiting, life-changing illness, which might include significant issues with symptom control, the need for challenging conversations, for consideration of care planning, and the ability to have much more of a dipping in and out approach to that over a longer period of time, I think is something that probably we would all say in the room has changed over the years that we've been working in the field. I think there's still a lot of stigma around it, and still a lot of tension really within some of the services around how many people they can cope with seeing and supporting. But palliative care in a lot of ways is just good care. It's understanding somebody as a whole person. It's thinking about them physically, emotionally, psychologically, spiritually, giving them the space to talk about some of those things that won't necessarily come up in a standard clinic setting. And really that's what we're all about.
Thank you, Emma. Claire, you've got your hand up. And you're on mute.
Sorry, I thought you'd unmuted myself. Sorry. Just to echo exactly from following on from what Emma has said there, I think it's probably really, really helpful to look at the sort of definition of children's palliative care. And certainly when you look at children's palliative care, you're looking from the point of diagnosis right the way through that journey, including symptom control and advanced care planning, right the way through to that sort of end-of-life care, the dying phase, a good death, and then following that bereavement care. So it's that whole process. And and very much as holistic around not only physical, but emotional, psychological, spiritual. And I think particularly in paediatrics, and hopefully we borrow from that within adults as well, we're looking at the care not only of the person, but of their family and of those who are nearest and dearest and most significant to them. I think the earlier those conversations happen, the better, really. So, you know, once we know we've got a diagnosis, which can be potentially life-limiting or life-threatening, then beginning to introduce palliative care and talking about it very sort of gently, because this is very much a process, really, of getting the adult or the child or young person on board, allowing them really to begin to sort of develop their own sort of thoughts and feelings, and certainly supporting their family and parents, etc. So I think the earlier the better those types of conversations happen. It also allows time to build up relationships with professionals, because this is very much a process. If you're looking at things like advanced care planning, it's not a tick list, it's a process, and it's a process of good communication and conversations that reflect wishes around what the care should look like and what a good life should look like, as well as a good death. Thank you.
Yeah, okay. Thank you, Claire. And I'm glad you've mentioned, well, glad's probably the wrong word, but you've mentioned the whole family as well, because it does affect the whole family, and everyone's affected in different ways, aren't they, in terms of how they cope with the whole process of a life-limiting condition. So thank you for mentioning that as well. So if we just move on slightly. So we cover over 60 muscle wasting conditions and other neuromuscular conditions. Within that context, we're very aware that palliative care is not appropriate or relevant to everyone living with a muscle wasting condition. But we know what a sensitive subject this can be, both to raise and how people may feel uncomfortable raising it as well. So I wondered if we could just discuss the circumstances around where someone may want to consider engaging with palliative care. It may be different per condition, but I think it would just be helpful to discuss that, if anyone's got any thoughts around that.
I'm happy. Yeah, I think it's a really interesting challenge to say that it's not always appropriate, because actually for almost any of those conditions, there might be situations where symptoms are not responding to standard measures. And in that situation, a referral and a review by palliative care or a palliative medicine specialist is entirely reasonable. It's entirely appropriate. And it would be an option to have that. And I think it's that sense that actually palliative care is not a one-way street. It's not a it's not an immediate route that you go on and then you are stuck in a cul-de-sac. Actually, you can dip in and out. And I think because conditions are becoming so much more complex, and there are so many other elements to conditions that people are living with, even neurologists aren't necessarily familiar with some of the approaches to symptom control, and being able to look at it from a slightly different angle. Everybody I know knows very well that I'm obsessed with bowels. And actually, sometimes when you talk to somebody about their symptoms, you discover that the issue was related to their bowels or was related to their bladder, and that might not come up in a normal consultation with neurology. So I think it's just trying to break that stigma that it isn't necessarily about you can only be approaching the end of your life or in a situation of significant deterioration. Sometimes that little bit of a review can be really helpful. And equally, giving people the opportunity to maybe talk in a clinical situation that isn't quite so time pressured as some of the neurology clinics. People might want to be able to have a conversation about sex or drugs or rock and roll. And again, you know, those things are not always easy to bring up. But because often from a palliative care perspective, we really are looking at the whole picture and everything that matters to that person, it maybe gives them a slightly different opportunity. So it's breaking down the barriers, not only for patients and their families, but equally for our colleagues who don't necessarily always know some of how we might approach things.
Okay, Emma, thank you for that. Derek, you've got your hand up.
I can confirm that Emma is obsessed with bowels. And that's a good thing to be obsessed with. So for me, it's about offering it's not our job sometimes to say this is too difficult for you. Sometimes people are rejecting things that they don't know what it is, but then once you've explained what it is and they're rejecting it, that's autonomy, isn't it? So what you don't do is hold it because they wouldn't want it. It's to say this is available. Is this something that would fit for you? And again, as what Emma and I have been trying to tease out a little bit, a lot of palliative care is just the symptom control bit. So if you're saying that we are referring you because you've got pain and the best people to help with are the symptom control people who happen to do palliative care, that's an easier referral than let's refer you to the hospice, which sounds like it's final. The other thing that we tried to do with some of the standards is to try and make it easy for people to see when palliative care might actually be a thing that you need to think about. So we produced a traffic light grid, which kind of does what's happening with your heart, what's happening with your feeding, and when people are in particular places in this, he's going, actually, this might be a time that we actually need to start getting you to know who the palliative care team are. So there's an individual thing about, have you got specific symptoms that might help? There's an individual thing about encouraging people to ask or encouraging people to say, I don't want it, it's not there for me yet. But then I think there is something, again, I'm sorry to bang on, but to try and produce some standards which say these are the circumstances under which palliative care would be involved. Here's something for you to look at. So it's not just a random decision, and one that, you know, we've got neurologists who refer everybody far too early, and we've got neurologists who refer people too late. What we're trying to do is maybe the Goldilocks thing. We're trying to get it at the perfect time to give guidelines and flags about what would raise that in your head.
Okay, Derek, thank you for that. Claire.
Thanks. I've already unmuted myself. I'm ahead this time. It was just following on from what Derek was saying. I mean, we're really lucky in Oswestry that we're able to work with Derek closely and have those links with the adult hospice. So often when we're seeing patients in neuromuscular clinic, that gives us an opportunity then, if we're beginning to pick up, as Derek said, we either know using our traffic light system that actually there are a few sort of warning signs there, perhaps deterioration with both the respiratory, cardiac function, acute admissions to hospital, etc., increasing loss of bulbar function. So all of those might give us a clue that somebody's moving further along that traffic light into the amber area. Or, as Derek said, where symptoms are becoming difficult to manage. And as you say, although sort of all neuromuscular clinics are very much MDT clinics, so they do allow the time that's needed, I think being able then to offer symptom control clinic where it'll be myself or one of the other specialist nurses together with Derek, and we're able to sort of see patients then separately, particularly focusing on symptom control. And it does allow us that additional time to be able to focus on symptoms, to talk about what palliative care is, and to introduce topics like emergency care planning and advanced care planning. So I think that's really, really helpful to sort of have that resource and have sort of like Derek working alongside us. And I would recommend that to any centres, having those close links with an adult palliative consultant. I think also alongside that, it allows us also to do some follow-up work with patients as well. So often perhaps myself and the other specialist nurse will go out, we'll do follow-up visits, we'll link in perhaps with GP, community palliative care, as well as the hospice. And I've also had patients who've contacted me directly and said, actually, I'd like to talk a little bit about advanced care planning or emergency care planning. And again, we're open to those discussions. So if we're approached, we're open to sort of support with that. And there are a number of ways that we can engage and support with those conversations.
Thank you, Claire. Really helpful. Shona. You're on mute, Shona.
So just, I suppose, looking at it from a different point of view, we focus very much on symptoms in the red light system, which we use here in Glasgow, and it works beautifully. Just thinking about the family as a whole, as Claire said, from diagnosis all the way through, is that actually, and I don't know the people that are participating today, what conditions they have, or if they're carers or they're actually living with a muscle condition, is that it's about support. You know that quite often when you are told that your child has a life-limiting condition, that the support might not be there, that actually you worry about phases of deterioration, phases of being unwell, phases of life where actually they might be so unwell that they might die, and getting support from Children's Hospice in that instance is really important. respite, as Derek mentioned, you know, there's a huge difference between child and adult services. Respite is provided by child hospice services. And that's a reason to get, you know, if there's no symptoms, if the family are doing okay, but there perhaps is a burden of care, then being referred for respite is actually really, really vital too. The children's services look after the children very, very well. And where I work, we work in transition. So we work between children's hospices across Scotland and also the PPW to transition them across. And we're always hearing that this time they're standing on a cliff edge. There's a void in front of them, and there's no adult services ahead. And that's not just palliative medicine, that's sort of their whole MDT. So actually, even at the point of transition, having a referral to a local hospice where you can have that really supportive multidisciplinary team with holistic care that can see them through into their adulthood, I think is really valuable.
Thank you, Shona. So if we just move forward and do ask your questions in the Q&A, if you would like to. So coming to you, Shona, you co-lead the young persons service at the Prince and Princess of Wales Hospice in Glasgow. Could you explain a little bit more about this service and how it began within the context of providing spaces in adult hospices? That would be really helpful.
That's a great question. So I suppose Prince and Princess of Wales Hospice is based in Glasgow. They had 4 townhouses on the River Clyde. It was a completely inaccessible building. And at the point that children's hospices across Scotland had to reduce their upper age limit because of the increasing numbers of young people, children and young people living in Scotland with life-limiting conditions, they had to reduce their upper age limit from above 30 to 21. And the Prince and Princess of Wales Hospice saw a need to be able to support that group of young adults. So there was 10 young men with Duchenne who joined the service at the old building, inaccessible. And really, at that point, we realised we needed an age-appropriate, accessible building. So they helped us design it and were involved right from the start, touring around the rooms and the spaces with VR, which was amazing. And they were one of the first groups of people that were welcomed into the building. They complain, the only thing they complain about is our front door. It's a heavy black wooden glass front door, and they're just like, it's not accessible, it's not automatic. But actually, it's one of 3 front doors, and it's the one that came from the old building. So it's about being welcoming to all. So the young adult service started very, very small with 10 young men with Duchenne who have really driven the service forward and continue to do so. We have 44 young adults on our caseload just now. Now, the far majority of those are with complex neurodisability like cerebral palsy, but 16 of them have Duchenne or other neuromuscular conditions. And they are pure Gallus. For those who are not Scottish, Gallus means cheeky and driven, and they actually drive the service forward for our young adults who lack capacity and are non-verbal. So they come to us. We are very much demystifying what an adult hospice is. We've got a changing place, which is open 24/7, so the public can come in and use it. We have a cafe and a shop. And really, people come in for coffee and cake first and foremost. I mean, coffee and cake can cure all things. And so they come in for a visit and a tour round. They'll come to we've got our symptom management clinic. We've also got a transition clinic from Chaz. And we'll go through their holistic assessment about how we can meet their expectations and address their needs. And then from there, we've got a very sort of medical model where we've got symptom management. But a lot of our young adults want to work towards achieving. They want to feel included. So we've actually got young adult social groups where they come along and interact with their peers. They have massage, they have sensory sessions, we have a hairdresser. And they also identified that they wanted to learn. Colleges and universities are inaccessible. So following on the footsteps of one of our young people, we developed a relationship with Glasgow Clyde College, and we've now got a learning hub in the hospice where, it's completely produced by the young adults, and they've currently just done a block of poetry, and we've got some amazing poems coming out from the young men with Duchenne. We've also working with a social enterprise called Raw Talent, and doing sort of social media rapping with Karen Dunbar, who's a Scottish comedian, and that sense of achievement is actually is huge. And we do a lot of carer support. So what we have realised, it takes time for relationships to come to fruition, time to build that trust and that confidence. And when the parents come in, you can see them, they're tense, visibly stressed for coming into the building. But over time, they gradually spend more and more time away from their young person and go and enjoy the cafe, enjoy a break, and knowing that the young adults are looked after. And our final sort of strand is that we have short break stays. So some people might think of it as respite. We're trying not to think of it as respite. And we've ran a pilot where we gave, it was 6 young adults with Duchenne, the rest are complex neurodisability. So there was a total of 13 who came in, and we were able to show that actually the young person felt included, they were achieving, they were becoming more independent. The adults, their parents and carers had more time to be themselves, to be with the siblings, to be with their friends. And actually the staff were benefiting from, it's not all about death and dying. You know, these young adults are funny, and they just give as much as they get. So that's our service in a nutshell, really. We are demystifying what an adult hospice is, trying to work towards establishing that transition model, and very much putting life into days. And of course we talk about death and dying, but that's only when it's appropriate to do so, and we're always led by the young person or their families.
Thanks, Shona. That sounds fantastic. And you have actually answered some of the next question, which I will partly just go into very quickly. So you've talked about the impact this has had on the young people, the families. The question was the impact which the young adult service has had on some of the adults across the services that you've been providing. So anything to add to that? I think you have covered a lot of it already.
Yeah, I think we very much use, it's the Scottish Government sort of policy, getting it right for every child. So it's about their well-being outcomes. So we measure that they're safe, that they're healthy, that they're active, nurtured, they are achieving, responsible, respected and included. And we evaluate across those, and we can see an improvement by attending our service. And especially with the Learning Hub, I didn't really expect it to be so popular, but that sense of achievement is huge. And the young people are facing so many barriers to get to education. It's a lack of understanding about their condition, a lack of understanding what they can actually do in class, a lack of changing place, a lack of accessible buildings. Even one of our most accessible buildings, which a young woman with congenital muscular dystrophy attends, there are 5 different levels and 3 different lifts that she has to go up across campus, and they don't have it in place. So they can come to us, not achieve the same level of learning. I mean, it's not a degree course, but they can have a celebration of achievement with their peers and their families.
Thank you, Shona. That sounds great. And I think it's a great resource to have, a great service to have. We probably need to spread more of them across the country as well, so a lot more people can benefit from such a great service. So thank you for sharing that, Shona. So just moving on a little bit, we've talked a lot about this already. So palliative care doesn't just focus, as we've said, on symptom control, but it should be a holistic, person-centered and cover other areas such as physical, emotional, spiritual care. Can we just discuss this a bit further and what this approach might look like for individuals and families? So anything else to add that we may have missed from that holistic approach to palliative care? And that's open to anyone, really. It's quite a general question. Looks like it's a slightly difficult one because it is so open-ended, but
I guess
Emma?
people struggle with spiritual
do.
care
Mm.
as if it's religious, whereas where I've come from now with spiritual care is it's about what makes you you, and discovering that and allowing that to flourish. So a person that we see is never the Duchenne boy.
Mhm.
It's the lad who happens to have Duchenne.
Yeah.
And that sounds like it's semantics, but that change in how you treat people rather than diseases on legs matters. So I think one of the reasons that I get an okay with the young folk, that must be sound so old, is that I'm just a reformed geek. So the fact that I have a Captain Jack coat, I have a TARDIS kind of notebook, and I play Dungeons and Dragons means that I'm 50% of the way there, because I don't know whether this is true out through the country, but for our particular cohort of lads who've got Duchenne muscular dystrophy, that ticks an awful lot of boxes. So actually just having a conversation with a healthcare professional about what is your favorite character class in Dungeons and Dragons, actually that's therapeutic, because it's actually talking to someone about something that's them, rather than tell us more about your symptoms. So I guess all I'm just throwing in is that the spiritual care bit, I think people get very hung up about. And in some senses it's huge, but in other senses it's simple. It's just actually remembering that that's a person. So start with the person, and then everything else should actually be able to fit into that. And play
Thank you,
Dungeons and
Derek.
Dragons.
Yeah, exactly. A really important point you've raised about it being person-centered, definitely. Claire.
Yeah, I think just following on from what Derek said there, I think you're right. Keeping things person-centered often means forming a relationship, getting to know somebody, giving them opportunities to talk, and being accessible. And one of the benefits that I suppose has really come out of COVID, dare I say it, has been access to online. So a lot of time now, it's very difficult, for instance, often when some of our patients would like to invite to symptom control clinic with Derek, or if I were to have some follow-up conversations with them, traveling can be really, really difficult. But actually, we now have the facility where people can join us virtually, and we can have some really quality sort of discussions with people and around what's important to them. So I think that person-centered approach is not so much, you know, in terms of what we see as the problems, but actually what does the person themselves see as important to them? What are their priorities of care for us to get right? And being accessible. So I think also you can draw on other members of the MDT. So for instance, we have a clinical psychologist who works closely with our service. So it might be really relevant that we introduce the clinical psychologist. Maybe issues around comfort and pain, where actually we can look at things functionally with a physiotherapy review or occupational therapy review. So all the time we're looking very, very holistically around what those issues are for individuals. But for me, the real key is trust and communication and building relationships.
Thank you, Claire. So we've talked a lot about palliative care, the needs of people for it being person-centered. Following on from these discussions, either people that are participants today or listening afterwards, if palliative care is something that individuals or families may want to explore further, or felt it might be relevant, how could they do this, and who would be best for them to contact about this? So I think it's fantastic when somebody realizes, yes, they do want to know more about this, but how can they actually learn more about it, and who would they approach? Would it be their GP, their neuromuscular consultant, and the whole pathway of it? That would be really helpful to discuss and just open up to everybody, really.
I suspect it's going to be different everywhere. And in a lot of ways, I think a little bit echoing what we've just been talking about, it's talk to the person you trust. And for a lot of young adults who've maybe come through the paediatric service, they've known somebody for a really long time and they've grown up with them. And entering the adult world, they're having to develop those new relationships and also develop a little bit more ownership of their own condition and their own life in the way that we all do as we get older. I think if there is somebody who's particularly linked with the neuromuscular service, then it's useful for them to be a point of contact, because the neuromuscular teams may well be able to say, this is our go-to person. And equally, if there isn't somebody, it might be that they then point them in the direction of their local hospice or their local specialist palliative care unit. And that's one of those big challenges, that there is such a lot of variation that there isn't a single answer to that, unfortunately. But I would talk to your trusted people. I'd probably talk to the neuromuscular team to see if there's any particular links that they've got, and then they can hopefully point you in some of the directions that you might be able to go.
Okay, thank you, Emma. Really helpful. Derek.
I've got about 5 buttons to press. I'm just remembering that Claire said she was very lucky to work with me. I'm holding that on today. I'm not sure that many people would agree with that they're lucky, or maybe it's the fiver I'd given her before we started.
It must be that, definitely.
One of my passions is that it's people themselves who are asking for this, and that's the driver, rather than healthcare professionals telling people that this is what they want. So part of our drive for everybody talking about advanced care plans, about writing wills, about letting people know, is actually this is more effective if it's kind of a general public saying, we want this conversation. So what I'm hoping from particularly what the charity's doing is that actually it will be families and people that have these conditions. It's them that are going to go and make healthcare professionals have to try and find out what's available, and if it's not, start to think about what should be available where it is. Because you're right, Shauna's service sounds amazing. I'm hoping that what we do in Shropshire sounds amazing, but those are just 2 little bits of the entire UK, and it shouldn't really depend on where you live of what you get. And in some senses, the driver from us up above is really, being harsh, is not as effective as people on the floor saying, we want this, where are you providing it from? So yeah, there's a little bit of us recommending to folk what they should have and recommending to services, but it really comes to the fore when people say, do you know what, I've got pain, I need someone who's a specialist in it, can you refer to someone? And if you don't know who it is, can you find out who that is, please?
Yeah, no, definitely. Thank you for raising those important points. So if we come to you now, Claire, in your experience and your role as an advanced nurse practitioner in neuromuscular care for children and adults, if it was appropriate, would this conversation usually be initiated by the neuromuscular team?
Yes, yeah, it would be. I should probably say at the beginning that our service in hospice, we're really lucky that we provide not only a children's service, but also an adult service as well. So we've got that lovely, families are with us, patients are with us right from diagnosis throughout the journey, and at transition, they continue to be under our care, which is excellent, really. But I think you're right, we will often, because often we are the team who are either initiating investigations and genetic testing, or if not, and they come to us with results, we'll certainly be the team who are perhaps breaking that news of diagnosis. So certainly we're breaking bad news about diagnosis. Sometimes that often is in a clinic setting, and it can be very, very difficult for patients and families to take that on board. So we always offer them that support of making sure they've got contact numbers for myself, for our clinical psychologist, and we pretty soon arrange a sort of phone call and a home visit, etc., following that initial diagnosis. If in particular that's a diagnosis which is palliative in nature, then we would again just sort of gently explore that, but we're not around throwing lots and lots of information to people, particularly when they're trying to take on board a diagnosis. So that's a very timely process of giving appropriate information, and the timing in which it's given, and time for questions, and time for families to be able to come to terms with what a diagnosis means for them. So I suppose the timing around sort of advanced care planning or emergency care planning, for me, it's very much a dynamic process, really. So some ways it sounds bizarre, but you almost feel your way around. I think you have to build that relationship initially, start to sort of get to know the patient and their family, explore what's important to them, and then begin to introduce subjects that perhaps, although they might be difficult to discuss, you need to be able to have those sort of open and honest conversations. So I'm hoping that was in answer to your question, Neil.
It was indeed. Thank you, Claire. Thank you. Really, really important points made there as well. So I know Derek mentioned the traffic light system, and Claire, in your biography, it mentioned that you'd been involved in the development of the traffic light tool for identifying patients with palliative care needs. Could you tell us a little bit more about that?
Yeah, I can do. Derek's looking. This is in conjunction, obviously, with the consultants in the Oswestry muscle team, Dr. Willis and Dr. Kulshrestha, and with support from Derek as well. So it was very much a collaborative approach. So we looked at models. I think we looked initially, it was the paediatric there was a paediatric traffic light model that was used in palliative care. And we looked at that and said, actually, how could we look at this model? How could we develop it so that it actually becomes appropriate for use in neuromuscular care? And so, if you like, that's where we looked at the different areas, really, in terms of, or indicators, which would indicate to us that a person was sort of perhaps moving closer to the point where symptoms were becoming more of an issue, and we really needed to be introducing the subject of emergency care planning or advanced care planning. So as an example, if somebody's green, it may be the fact they have a palliative diagnosis, but they're very stable. And I suppose an example of that might be a young person with Duchenne, if you like. So they're clinically stable, they have got a palliative diagnosis, so they sit in the green area. But once you're moving towards amber, where symptoms are beginning to become more apparent and where you're beginning to perhaps rely on non-invasive ventilation, perhaps you have cardiac implants, etc., supplementary or PEG feeding, you're then beginning to move into an amber area. And at that point, then it triggers us to sort of say, actually, we really need to begin talking to this person about their emergency care planning. And very often that's a choice thing. It has to be something that somebody's ready to have those conversations. So it's around sensitive introduction, but then a partnership, really, of somebody being willing to sort of to have that engagement and to take part in that planning. Obviously, we'd like to start those conversations in that amber rather than get into an area where somebody's in red and they've actually, the condition's really deteriorated. Perhaps, you know, they've had a number of acute admissions in hospital and they've been on intensive care, etc., and they've been life-threatening episodes. At that point, although, you know, we can start those conversations, we'd much prefer to start at an earlier point. And what we usually try and say is we'd rather have had those conversations about emergency care planning and advanced care planning before somebody comes to hospital as an acute emergency, because at that point then very often you will have other health professionals who are not as well known to the patient or a family who are going to start having those conversations with them, and very often this might be around ceilings of care, etc. And if the person themselves perhaps isn't in the best place to be able to engage in those conversations, it's really important that they've been able to do that in advance and they've made their wishes known, and that they've shared those with their family as well. So we very much try to sort of engage as early as possible in emergency care planning, and so that those tools are held with the patient, with their family, and that they're shared with local health professionals. We also, as a key part, ask families to contact us as soon as their relative has been admitted to hospital, so we can start that engagement, because we work with a number of tertiary hospitals. We will then proactively contact the teams caring in the acute centre. We will then make sure that we share clinical records, discussions, emergency care plans, respect to. So we'll start that active engagement. And very often things like emergency care plan and advanced care plan are as much about what treatments you want as well as what treatments you might not want. So I'm sorry if that's a rather long answer to the traffic light too, but it gives you an example of how it can be used and the fact that we'd like to do it earlier rather than later.
You're on mute, Miru.
I have not been on mute throughout this session, and the one time I went on mute, never mind, I do apologise. Right, I'll have to backtrack now. Claire, thank you for that and all the detailed information you provided. You've mentioned about advanced care planning. I have got a question about that in a moment, but I'm just going to go to Derek first, who has his hand up.
Just to say that we've tweaked the traffic light system specifically for patients or people with myotonic dystrophy. So as an overall thing, it actually worked really well. But we started to find as we did more that there were specific things for this specific condition. So we now have a traffic light system specifically for our patients who've got myotonic dystrophy, because we have a specific myotonic dystrophy clinic. It'll be interesting to know whether we kind of keep this global thing, because the problem is if you make too many of these things, it just gets confusing about which system you're going to use. But it's interesting that we found that this thing worked really well generically, but for this specific condition, there were bits that actually weren't capturing with it. So we've tweaked it a bit. So we've got 2 sets of traffic lights.
No, that's great. And I think it's great you've mentioned myotonic dystrophy, because we did a training session for people within emergency care, and that came up quite heavily there as well in terms of the differences and changes you do need to make for patients with myotonic dystrophy. So really interesting.
One of the things that I've learned through being invited into the world of neuromuscular conditions is on the outside, I thought my job's going to be dealing with folk who've got Duchenne muscular dystrophy. And yes, that's part of my job. But I've discovered that there's this whole other bit that as a palliative care physician, I had no idea about. So I'm really pleased that this is about neuromuscular conditions as a whole, because yes, the patients with Duchenne muscular dystrophy have particular things that you need for them. But actually, it's not the whole story, is it, for what palliative care should be providing? And I think adult palliative care sometimes is really guilty of just thinking it's about this particular group. And yes, it is about them, but it's about them plus. So that's one of the things I keep saying to people. Please don't think you've covered neuromuscular conditions if actually you've seen an adult with Duchenne muscular dystrophy. There's probably, for that one patient with Duchenne, you've probably got 5 or 6 people with myotonic dystrophy who, by the nature of the condition, the fact that they're depressed very often, that there's a lack of motivation as part of the condition, and actually voice goes, doesn't it, because of the ability. So literally sometimes people with myotonic dystrophy cannot speak up for themselves. So yes, I'm just sharing that I've been converted to thinking that it's a lot of conditions, and trying to understand the particular things for that condition, what's common for them and what's particular, is something that we're all on a journey to try and work out.
Yeah, and like you say, it is a journey. It's a journey for the people with the conditions, as well as you learning more about the conditions, definitely. And I think even within a condition, everybody's individual and different. So we've talked about very much person-centered rather than condition focused. So yeah, really important to raise that today. So we've mentioned advanced care planning. We've sort of talked about it. I wondered if we could go into a little bit more detail about best practice for advanced care planning, because that term's used quite often. I'm not always sure people understand it fully. So just open to all of you really in terms of best practice for advanced care planning.
I think the biggest thing is understanding the individual, to be able to then try and build any kind of advanced care planning or emergency care planning. And actually, Claire, I'm with you. I really think this is about emergency care planning rather than necessarily the traditional model of advanced care planning, which is often thinking about where somebody may wish to end their days, where they may wish to die, whether they would want to go to hospital and so on. It's thinking about the types of situations that they may find themselves in. So there are often predictable problems that we can talk through a little. And the key understanding in trying to develop guidance is around knowing what matters to that person. And actually, rather than for me, rather than what somebody would want, it's a little bit more about what somebody, situations that might feel unacceptable to people. So it might be unacceptable to somebody to be in a situation where they couldn't go back home if their care needs couldn't be met in that situation. And actually that gives you a really good premise of a place to start to build any kind of guidance around care in terms of shaping that to try and achieve those goals. That's really what you're trying to do. You can't necessarily predict the exact situation. You can't predict whether it's going to be a Tuesday or a Saturday or a bank holiday. Usually it is, but nonetheless, or where you're going to be. So if you can understand what matters to that person, then you can start to build a picture over how to approach treatment. And if there are certain things that should be avoided, for example, or if there are certain things that we should focus on and concentrate on. And that's really the key picture. And there are loads of tools out there. There is the Respect Plan. There is the Children and Young Persons Advanced Care Planning document. There are condition-specific documents as well. And really, you can use almost any of those structures. And I think one of the things I often encourage families to do is to actually look at this together, because it's just a good thing that we should all talk about a little, you know, what matters to you, because we never quite know what's around the corner and unexpected things can happen. And if you've had those conversations with your loved ones, then hopefully if somebody does find themselves in a situation of not being able to speak for themselves, then you've got that little bit of knowledge to be able to try and advocate for them as well. So yeah, lots of different elements.
Thank you, Emma. Shona.
Just echoing what Emma says, I think, you know, we all have a responsibility to think about our sort of future. And in Scotland, we're moving towards future care planning rather than an advanced care planning or anticipatory care. And I guess, in our society, death is feared. It's not thought to be as a normal. People are living longer and longer with treatments. And I guess that we all have a responsibility to open up that conversation about what happens if we were to become so unwell that we might die, that we have a responsibility to share with our families what we would want, where we want to be, what we wouldn't want, I think is a really important thing, because for example, my young adults don't know what they want, but they definitely know what they don't want. You know, they might not want a tracheostomy, they might not want peg fed, but they're not quite sure other than that. So I think that going forward, sort of over the next few years, I think advanced care planning or future care planning will become easier as palliative care and death are sort of acknowledged and sort of demystified. There's a digital sort of app, My Wishes, where people can actually create their own account and do some treatment escalation plans there, or they can put their wills there or their documents. And I guess what follows sort of in line with this is about power of attorney as well. You know, if our young adults or the adults themselves lose the ability to vocalize their wishes, then who is going to support them to make sure that their wishes and needs are heard and followed? So I think parallel, and I think, yeah, it's demystifying advanced care planning. It's normal to think about the future. It's normal to think about, oh, actually, I really like that song. I'd like it to be played at my funeral, or I'd like to be cremated or buried. I'd like to have this poem read. It's okay to talk about these things.
Yeah. No, I think you've raised some valid and really, really important points. And a follow-up question was going to be about advanced care plans and where they could be held. So the My Wishes app, really, really good. And then that question is asked quite often. I've not got access to a palliative care consultant, but I have these wishes. My family's aware of them, but who will hold that information from a medical perspective? That comes up very often indeed, definitely. And it's a difficult conversation to have. And I think we've come across people that don't want those conversations. I've got a brother who's got Duchenne. He's 40. He turns 41 in January. He has not had that conversation. I've broached it a couple of times. Maybe I'm the wrong person, but it's a really, really, really difficult area to talk about, especially for families, I think. And I think I separate the family from my professional perspective. Maybe I need to go in with a different, but really difficult conversations to have that are really important to have, so your wishes do come through when they really, really matter. Emma, sorry. You've had your hand
No,
up as well.
I think you've absolutely highlighted it, Nira, and it is difficult for everyone. And I think that's the other really important thing, is that just because you are diagnosed with a life-limiting illness doesn't mean that you suddenly want to talk about things in, or that you're suddenly comfortable with it, or that you're suddenly not comfortable with it. And so that's just being human, because many humans don't want to discuss things. Sometimes it's broaching it from your perspective. So actually, rather than asking the person what they would want, you saying what you would want, because that might get them prompting to think about what they might want. And I think the other thing that's so important is that it's an evolution of a conversation, because what I wanted when I was 20 is probably very different to what I might want when I'm 40 and when I'm 50 and when I'm 60. And we all change. You know, the song that we hear might not have been written yet. And so it's important that we revisit things and revisit it in the context of how somebody is at that moment in time. And I guess the other thing is that, hard as it is, it's also important that people are allowed not to talk. And sometimes people just don't want to, no matter how much you try and open those different avenues. And people can say, I don't want to, and they can nominate somebody, as Shona said. They might say, do you know what, you know me really well. As a clinical team, you know me really well. So I'm going to trust that you know me well enough, and that's fine. And as long as people have what we call capacity, which is that they understand what it is that they are saying yes or no to, then they're absolutely at liberty to be able to do that. And just one other final point is you mentioned about who can hold information medically if somebody isn't known to specialist palliative care services. GPs absolutely can, and they should know their local systems. So often there are local networks with regards to digital sharing of information. We always have to be careful with information governance and making sure that information isn't too easily accessible. But even things like a WhatsApp group with your family, where you can take photos of certainly key documents if they're written or similar, it just means that they're quite quickly accessible, because often you forget where things are in an emergency as well.
Okay, thank you for raising that. Really, really helpful. Claire, you've got your hand up. You're on mute as well.
Sorry, I think Shona had a hand up before me, so I think that's.
I don't know whether Shona's is a residual hand.
Was it historical? Sorry, Shona. I was only going to say that where we know patients do have an emergency care plan or respect form, etc., then we will make sure that it's annually reviewed as well. So each time we see them in clinic, we'll usually sort of say, you know, oh, well, actually, we know that you do have an emergency care plan. You know, would you like to discuss it? And exactly as you said, Emma, because things change over time. Things are very much sort of dynamic. And, you know, are their thoughts and wishes still the same? Or actually, for some patients, they might have thought a while ago that they would get to a point where perhaps it would be the ceiling for them in terms of, when I get to this point, I'm actually perhaps going to be certain things that I don't want to be done in terms of interventions in an emergency. So I think allowing that opportunity, so gently sort of bringing it up again and saying, actually, is it okay if we review your emergency care plan? And you know, are things still the same? Are your wishes still the same? And just to echo exactly as Emma had said as well, actually, you know, people are not under an obligation to have to talk about dying. We'd welcome those conversations, but for some people it's very, very private, and they're very much sort of thinking they're getting on with the business of living, and they'll think, I'm not ready for that conversation yet, I'll know when I am. And I suppose it allows us that if we're there and we're approachable, that when they are ready for that conversation, we're ready to sort of receive those messages and take things forward with them.
Thank you, Claire. Shona, you've raised your hand.
Yeah, I just wanted to actually, I think it's something, it's almost an elephant in the room. I think that advanced care planning shouldn't be confused with resuscitation status. I think just with COVID pandemic, and I know that there were many concerns raised by the muscular dystrophy community about do not resuscitate orders being put on to people with disabilities. And I think that we need to separate these two distinct areas. Advanced care planning is about everything that is done for an individual up to the point that their heart might stop or their breathing might stop. And it might not, might be that they decide to take on a decision and record a decision about the resuscitation status, but actually, again, it can be revisited over time. What's most important is that what happens when you're unwell, that that you're in hospital, because actually everything will be done up until the point that your heart stops or your breathing stops, and that resuscitation is something else to consider. So they shouldn't think that advanced care planning is about resuscitation status. I just wanted to make that clear.
Thank you. No, it's good that you have made that clear. That's quite important. So we are going to be closing off soon. I just wondered if any of you we've lost Derek along the way as well. I was in the hope that he'd come back in, but maybe he's had some IT issues or he's had to be somewhere else. Any closing comments of things that you feel we haven't talked about, or are you quite happy that we've gone through most things? I will take that as an assumption that we have, so that's great. And it has been a really interesting conversation today. So unfortunately, that's the end of today's session. I'd like to thank all our panelists and the people who've helped guide the discussions with good questions and comments, especially the ones in advance. You can see the recordings of all our seminars on our website, and the recording of this session will be posted there later this week or at some point next week. We will also be in touch with a short survey to gather some feedback on the session, which will be invaluable as we shape how we do these in the future. And a reminder, MD UK's virtual seminars are a source of information, but should not replace direct advice from your own specialist consultant or healthcare professionals. If you have any concerns, you're advised to speak with your neuromuscular clinical team or health professionals directly. So thank you all so much for joining us today. And it's been a really insightful conversation with lots of information sharing of really important information. So thank you all for attending, and thank you to all the participants. Thank you.
Thanks, everyone. Thank you.
Thanks very much, everyone.
Thank you.
Bye-bye.
Thanks.
Bye-bye.
Bye. Bye, everyone.